Welcome everyone, and thanks for staying after the lunch. I think we should talk to you before lunch. I know half of you are asleep. You'll have noticed on the way in that there's the October Beer Fest going on the other side of the hospital as well. So I will be brief. And I'm usually quite loud. To re-emphasise what Chris has said, CLL is really quite an amazing disease. In 20 years ago, you couldn't get much in the way of funding for CLL. It's a disease of old folk, and all the money raising was for children, children and children again, or breast cancer, or these sort of things. And it's been to the great credit of the LLR that they saw ahead of the game that CLL was a phenomenally important disease. The thing with CLL is you can get the cancer cells every day from a patient, and it's told us an awful lot about cancer per se. If you have lung cancer, you get one biopsy when they put the tube down, then the patient's either cured or died. You can't do any further research to see what happens to that tumour. With CLL you can. You can collect it again and again and again from the same patient and try and work out what gave the patient CLL, what makes the CLL grow, and what makes the CLL cells respond to treatment or not. To emphasise again for Chris, 1960 was also the year I was born, so it really was a good year for CLL. And it was also the year where chlorambucil was first used for CLL, and we're still using it today. 52 years on, but we're about to go into a brave new world, if we can afford it. And I'll touch on that at the end. Why they asked me to talk about problems faced by patients with CLL, I'm not sure, because I don't have CLL myself, as best I know. But I may have, because we know 1 in 30 normal men over 60 have a touch of it. I was born in 1960, so I haven't got there yet, but no doubt it's probably waiting for me in the future if I live to 150. I don't think there's much chance of that with the woman I'm married to. But I don't know really what the problems are, because I've never had CLL. I'm going to try to share a few of the insights with you. First and foremost, the diagnosis of CLL is very vague. Very often patients go back and forward to their doctor many, many times. 70% of patients are actually found by chance. Now those found by chance, half of them, with modern technology computers, I can find an abnormal blood result from previously when they came into casualty, when they had their hip operation, when they had their prostate done, all those things that happen to us as we wear out a bit. But the symptoms are very non-specific unless you get lumps. And when you get lumps, even GPs manage to stop texting their bank manager and actually take notice. Yeah. It's important, you know. It's their monies are being invested in shares which are paying for your pensions. So don't be too hard on them. Don't be too hard. But of course, the symptoms can be very non-specific: fatigue, sweat, fevers, weight loss, lumps, abdominal swelling. Of course, 70% of patients are actually found by chance. They didn't know they had CLL. They had no idea what was going on to them. So one moment, you're going in with something, hip replacement, and the next minute somebody comes along and says, by the way, we've got the haematologist to see you. You know, what's that about? Something not quite right with your blood. Well, what the hell does that mean? And in the old days, we never used to tell patients they had CLL, or patients. We used to say there was something wrong with your blood. Whereas nowadays, virtually everyone gets told what's actually going on. CLL is a very heterogeneous disease. We have a database here made up of Cardiff and Birmingham patients talking about collaboration, and we've got 924 patients data on that database, which the longest going CLL is 1979, still going and not needed treatment. So why the hell do they not need treatment when people turn up with bad sweats, bad fevers, needing treatment almost immediately? What is about the patients which is so different? And you need massive collaboration to try and work down to these subsets of what makes this person different from that person, different from that person. It is far from straightforward. And you have to work together. It's almost like an old-style communist regime, you know. I know I'm running the car factory, but I'm worth the same as the cleaner. It's very much like that in CLL. At least we like to tell ourselves it's like that too. Some are more equal than others. But we've got our funding, so I think it's absolutely fabulous the way it's shared out. The word leukemia is very emotive. So the first problem is faced by the people who are telling you this. How do you say it to them? Breaking bad news. And they used to say, and some of you may have heard this, the bad news is you've got leukemia, the good news is you've got CLL. What the hell does that mean? The word leukemia dominates everything. You may as well shut up the moment you mention the word, go away, go to the toilet or whatever you do, come back and then talk to the patient again. Because most people, especially the asymptomatic, they're not expecting that. That word has enormous connotations. Most of our view of leukemia care is from television. It's usually a bald-headed child vomiting into a bowl, because that makes great telly. Saying this is Mr. Jones, comes along, has a treatment, goes into work, doesn't make great telly. And in CLL you see a whole spectrum of all sorts of things. So what were your thoughts when you got told you had leukemia? Was it, I should have ditched the wife, if I've only got a few years left I should have run off with my missus? Was it, I hope I live long enough to see my children get married? Was it really ambitious, I hope to live long enough to see my children get divorced? It has enormous connotations, the word leukemia, and it's obviously very upsetting. And what does it mean for your general health? Will I be able to work? Will I not? Will I be able to pay my mortgage? Will I not? Am I going to live a normal life? Am I not? When I try and get a car and they say, have you got any illnesses? And you write down leukemia, you can hear the till go ka-ching if they're about to take the money out of your pocket and stick it in their till. It has enormous connotation, even for those people with early stage disease who don't need treatment. And that term, watch and wait, is again a very... Who was told that we're going to watch and wait? Yeah, well, what the hell does that mean? I don't know what it means, and I say it. Every time I say it, I think, you've got to come up with a better set of words than that, Chris. Watch and worry? Yeah, watch and worry. Well, very interestingly, I'm going to show you some work later from a fellow called Tate Shanafelt from the Mayo Clinic, who presented some data in 2007 about people with very early stage disease who don't need treatment. And usually your doctor thinks about if they're seeing every 3 months, 6 months or 12 months, or some of them we don't need to see anymore, back to your GP, as some of you may have been told, that actually we think about the patient coming in the room for about 2 minutes before the patient comes in, when we read the notes again, and you're trying to put the face to the name if you've only seen them 12 months ago. But these patients, even those who haven't had treatment, think about their illness every other day, at least in America, because of these effects on life. You can't get a loan for a car in America if you've got CLL, even if you don't need treatment, because you can't get insurance. And it's similar in the UK. It's an amazingly oppressive word, is leukemia. And for a lot of patients it doesn't need to be like that, and hopefully in the future we can actually get rid of that completely. What help is available? Some patients get offered help. It's stage A, nothing needs doing, we'll see you in 3 months. The door swings open and you feel the proverbial boot up your backside, in other words, get out and let me get onto something, you know, needs treatment or whatever. And a lot of people feel very helpless. They go home and they tell their loved ones, what do you say to the children? Because you don't know yourself what to say to the children, because the information is not very good. And again, the Leukaemia and Lymphoma Research, there's patient support groups in the UK, have a wealth of information of what it's like to have CLL and what it means for you as individuals. The problem is every patient is different, how it actually impacts to you and what it really means. We know the biggest thing that patients come to me with is fatigue. I just feel shattered, doctor. How many of you had that feeling when you said that to your doctor? His first thought that went to his head, well, I feel bloody shattered as well, but I've just got to get on with it. Because fatigue is not something easy to quantify in terms of daily living and what it means for you. One person's fatigue is another person's laziness. You know, Department of Works in pensions, I'm getting lots of letters off them saying this person says they're too tired to work, but they tell me they've had no treatment. You know, every patient is different. The impact on them is different. But fatigue is very real, and the more advanced your disease, the more tired you feel. And of that there is no doubt. In your general health, you can split general health into physical well-being, social well-being, emotional well-being, and functional well-being. Whichever parameter you look at in CLL patients, and we're here to talk about people who don't have treatment. We're not talking about those who are getting chemotherapy. Well, obvious you don't feel right. These are people who haven't had treatment yet. But it's very, very subtle. Why do I feel shattered? I can't sleep at night. I'm worried about money. My boss at work is a complete swine. And that's what it gets attributed to. But for an awful lot of patients, it's CLL doing it to them. And you probably had great trouble feeling you're getting doctors taking you seriously when you say you feel tired or just can't do it. The quality of life is phenomenally lower, and one of the reasons why the quality of life is lower is, unfortunately, as we get older, those 4 wheels on our wagon become 4 creaking wheels, 3 creaking wheels, 2 creaking wheels, because other things happen to us. The heart's a bit dodgy, the joints are a bit dodgy, the lungs are a bit dodgy. Everything goes, I'm afraid, as I move towards 60 in age. I'm looking forward to it. No end. I found my first grey hair when I was 15. Yeah, well, some things we can't cure. But that's not actually true. Just for Chris's information, it's a bit late. If you've got no hair and your children are worried, you can actually treat male pattern baldness by simply removing the testicles when you're young enough, and you'll keep your hair. You lose something else on the way, I gather. Probably ridicule from the opposite sex is what you mostly lose, but we won't go there. We haven't got time. We're talking CLL. But CLL doesn't occur in isolation. You have other problems, other health issues, which all compound each other. And of course, the chemotherapy or treatment for CLL may help the CLL. It doesn't really do much for anything else. But the other things impact on how well you can actually tolerate the treatments we've traditionally used. Again, there's all fancy ways of measuring this and quantifying performance, how you feel, how your well-being is, and the worse your disease, the worse you feel. Everyone gets worried about talking about emotion. You know, I know we're in Wales. The Welsh are very emotional about everything, especially the sheep. But there's a few other things they're emotional about. But this is, again, a simple thing. Ask one of those 7 questions. This was since you were diagnosed with CLL. In the last week, how many times did you feel sad, felt you were coping, losing your fight, losing her, feeling nervous, worried about dying? And the interesting thing about this study is you're told there, 6 months on, you're still like that. But in fact, you don't really lose that feeling as you go through your illness. And you'll go in there and the doctor will say, nothing's happened in 3 years. You're okay, nothing's happened. It doesn't actually make you feel much better about it all. Because they say, but we don't know what will happen tomorrow. Or to use the banker's analogy, past performance is no guarantee of the future. Well, it is, because we'll lose money, hands always, with bankers and insurers. We do know past performance does match the future. You're going to be done for cash, aren't you? What people don't often understand with CLL is in most places we have what's called a multidisciplinary team meeting where all new patients are discussed. Or as I like to put it, we talk about you behind your backs. Where the so-called multidisciplinary team get together and talk about the individual patients, what symptoms they've got, what their stage of disease is, what their treatment is right for them, and come up with what's called a treatment plan for each individual patient. In theory, this should be happening with every patient in the country, and on the whole it does. But what you need is people around the table who actually know something about CLL and the various guises of it. So if you're in a small place, you may find there hasn't been much discussion about you. In bigger places, it's more likely to happen. And then you get on to this thing about prognosis. And this exercises everyone. Does actually, what's going to happen to me? Back to that, the bad news is it's leukemia, the good news is CLL. Well, the average time in CLL to treatment is 12 years. The trouble with average is that 25 years or 1 year. It doesn't mean a lot to you as an individual. But the clinical stage you're at is the most important thing immediately. I'm afraid the older you are, the worse you're going to do. We can't make 90-year-old people back to 70 again. I wish we could, because I'd have earned a lot of money now and would be with the floozy, leaving the missus behind. She would be off with her fella, don't worry, it's a two-way thing. And testing, prognostic markers testing. Wherever centre you're in, you'll be offered different tests. You may not be offered any tests. You would have heard of CD38, ZAP70, genetics. What the hell do all these mean? Why are they not doing them? Why are they not telling me what the results are? And a lot of the argument for that is because actually they're just not specific enough to tell you as an individual what's going to happen. If you take ZAP70, 70% of the time it predicts it right and 30% it doesn't. So that's really not a great test. It gives us ideas of trends. It tells us something about disease at ZAP70 matters, but actually doesn't tell us much else. P53 testing is the most important thing because that determines what treatment you should have. If you want to ask as a patient, even ask yourself how well are you doing. You don't need those doctors. The most important thing is what's called the lymphocyte doubling time. And this is a study published earlier this year, back to collaboration. It was 4 UK centres with stage A patients, early stage patients. With those tests you'll have heard about IgVG8, CD38, age. ZAP70 isn't on there because it came out as irrelevant. CD38 came out as important. The most important thing, telling you an accuracy, 7 patients versus 1, was lymphocyte doubling time, beat every other single thing. So you can tell yourself what's going to happen. What was my lymphocyte count when I was diagnosed, and what is it 12 months later? And if it's doubled, you're almost certainly going to need treatment. If it hasn't doubled, you have a 7 out of 8 chance. You're going to be okay for the medium long term. You don't need doctors, you don't need nurses, you just need yourselves. You probably learnt that anyway, haven't you? Moving on. Back to the complexity of CLL. How do you know if the advice being given you is correct advice, especially if you actually feel okay and the relief is you don't need treatment? Or maybe the relief is you do need treatment, as in, I've been feeling awful, at last they're going to give me some treatment. How do you know if that's the right treatment, and how do you know it's the right treatment at the right time? Back to my friend, Dr. Schanefeld at the Mayo Clinic. Hands up if you don't get on with your colleagues at work. Not the lot who work here, I mean in the audience. Hands up if you've had trouble with your colleagues at work. Only one honest person in the place. Oh, come on, yeah. What Dr. Schanefeld did at the Mayo Clinic last year, they have 42 oncologists who look after CLL. 7 of them call themselves CLL experts. The other 35 don't, but they look after CLL. Given that the Mayo is one of the great cancer hospitals of the world, what Dr. Shanafelt did is publish the survival of patients who were under someone who called themselves an expert. They may not have been experts, but it's on their websites they are. But anyway, it showed you got treated less if you were under an expert. The non-experts treated you earlier. However, when you look at survival for patients, with the non-experts, you die quicker than the experts. So if you're under someone who really doesn't understand the nature of the illness, you get treated earlier and you die quicker. And that's why getting these multidisciplinary teams together so everyone discusses everything has been a big jump in advance of knowledge, and it's going to get even more complicated as time goes on. I got a job for life. CLL is phenomenally common, but actually I'm going to retire at 60 because I think it will probably be job done with CLL. We will have sorted it with the help of great institutions like the LLR. The reason why I can say this is all this investment for 20 years in basic biology of disease. Why do some people live 40 years and absolutely nothing happens to them? When I look down the microscope, it looks the same as these other people's whose disease is running wild. There are new treatments coming along. And this is going to be another important aspect of it, is which treatment do you get? In which order do we schedule it for individual patients? One person once said to me, you don't need 10 treatments, you only want one that works. You wouldn't need the other 9. So why are there 10? There's 10 because no one's being cured. And no one's using the C word quite yet, but these new agents are very, very different because they are not chemotherapies. We know what makes the cells grow. It's a thing called PI3 kinase, and there are now tablets undergoing studies to actually specifically block that and make that little CLL cell decide to die, leaving the others alone. Same time, a thing called BTK inhibitors. They are virtually side effect free because they're not chemotherapies. We'll be opening these studies here in Cardiff and elsewhere in the UK, and Guy will talk a bit more about that. We've just completed a study with a monoclonal antibody called GA101. And GA101 is super rituximab. It's about 10 times better at killing CLL cells than rituximab is. And rituximab improved things by 10 to 20% in CLL when it was introduced. So GA101 is coming along. I've given it to 6 patients. The first one I gave it to, their white count went from 177 to 4 in 1 week. And it's an antibody. It is not a chemotherapy. And this thing called CART, which I'm just going to explain a bit to you, because that is coming as well. This is immensely complicated. I've got to pretend I know more than you. You have things called CLL, which is a disorder of B lymphocytes. There's another type of lymphocyte called T lymphocyte. And T lymphocytes fight cancer and do your immunity for you. What they have done with this treatment is you go on a cell separator, they take your T cells off you, you send them to a lab, and what they do is spice them up and activate them against your CLL cells. And 2 weeks later they send them back to you and you squirt it in your arm with a syringe. They're your own cells and you go home. This is a bone marrow with CLL. Day 23, 6 months, there is no CLL. Here's a glance, this is a CT scan. Imagine yourself being sliced in half. There's lymph nodes in the axilla. Was I trained in Newcastle, you Oxter. And those are getting smaller and disappearing. And these are your own cells being activated, titillated to kill your own CLL cells. So we have 4 major treatments coming along Here in Cardiff, we've been looking at other things to switch on your T cells. There's certain things with that which are potentially problematic. So one of the ways in the future challenges to patients is actually getting access to these new treatments and new trials. We're going to hear more about the trials shortly. There is a thing then of getting these drugs licensed. Those all inhibitors are estimated are going to cost something like £60,000 per patient per year for life. So are they going to get licensed? When the trials are finished, while you're waiting for them to be licensed, the trials are finished, what's going to happen in the interim? Because that may take a year or two. Are we going to have access to agents after that? Then, of course, we've got a unique British institution called NICE. I've been to NICE 4 times, and I've yet to lose. But, yeah, it's going to happen one of these days. They're going to be shocked at the developments in CLL. Figure all this solid tumour nonsense, pancreatic cancer, turning 4-month survival into 5 months. Isn't that wonderful? Here's your £50,000 for that treatment. They're going to have something of a completely different paradigm to get to grips with. Because actually we're going to sort this out. And ultimately funding from government bodies. It's a whirlwind time. It's the most exciting time in what for me in CLL is the most exciting disease there's ever been. Because actually we're going to beat it. We're going to learn an awful lot about lots and lots of other cancers, which is going to enable us to transfer this information to other settings. I'd like to thank the LLR for all their support they've given us over the years. I say it was difficult 20 years ago to get money for CLL research. It was a disease you could live a long time with, whereas acute leukemia, people didn't live a long time with it. But we made enormous progress with their sort of help. The job is not finished by a long shot, but we're going to finish the job, I absolutely do believe, in the next 5-10 years. Thank you very much.